So the first thing I want to do is to welcome you to the San Francisco campus for Jewish Living, but also in terms of some housekeeping, let you know that if you need the restroom, it is down the hall and to the left. So please feel free to get up if you need to during the conversation. I really appreciate everyone being here tonight. I am Adrienne Green. I am the Chief Executive Officer here at San Francisco campus for Jewish Living. Are you having a hard time hearing me back there? Okay, how's that? I think I just need to get closer to the mic. Thank you, Art. For those of you who are joining us here for the first time, I thought that before we introduce our speaker, I could tell you a little bit about the campus. The campus is comprised of the Frank Residences, which is where we are right now. And this is a new 190-unit assisted living and memory care. And then the other part of our campus is the Jewish Home and Rehab Center, which is the largest private nonprofit distinct part skilled nursing facility in California. JHRC includes a post-acute rehabilitation center as well as long-term skilled nursing. And then we also have a sort of somewhat unique 12-bed acute geropsych unit. On any given day, we have over 500 patients and residents here on campus, and over the course of a year, we serve over 2,000 patients and residents. Since we were founded in 1871, we've embraced the mission of enhancing quality of life for older adults. Our philosophy is founded on Jewish values, including respect for elders and responsibility for the welfare of others. We pride ourselves on providing older adults and their loved ones with life-enriching programs and services to improve and maintain their physical, cognitive, and emotional well-being. In fact, one of the things that brings me the greatest joy is being able to walk around and on any given day, seeing our staff and our residents engaged in some of those activities. So in the spirit of that, we welcome you here this evening, which marks the second gathering in our new speaker series called Community Conversations that Reimagine How We Age. This series was generously sponsored by the Julian S. Davis Lectureship Fund, and it was actually in the works for several years, and we were able to have our first presentation just this past October. And we're very, very happy to have those of you who are here for round two join us again, and others who are here for the first time to enjoy this presentation. These conversations came out of a collective realization that the process of aging, which we are all experiencing every day, is often looked at in a way that doesn't leave much room for nuance. And through this series of conversations with healthcare experts, we hope to provide thought-provoking, insightful, and practical resources that all of us can use as we have meaningful conversations with our loved ones, no matter where we are in the spectrum of aging. So without further ado, I would like to introduce our speaker tonight, who is Dr. Rebecca Sudore. Dr. Sudore is a geriatrician, palliative medicine physician, implementation scientist, and professor of medicine at the University of California, San Francisco. She directs the Innovation and Implementation Center on Aging and Palliative Care Research, and then NIH, or the National Institutes on Aging funded Vulnerable Aging Research Core at the Pepper Center. She is the creator and director of the evidence-based online Prepare for Your Care Advanced Planning Program, which you'll hear a lot more about in a minute, the Prepare Easy to Read Advanced Directives, and the online Prepare for Their Care program. We are so privileged to have Rebecca here with us tonight. Rebecca will give a short presentation, and then we'll engage in a Q&A with Dr. Ann Kinderman. So I thought I would just take advantage of this time to introduce Ann as well. Ann is over here in the audience right now, and we are very fortunate to have her here as our very own palliative care doctor. Dr. Kinderman is a clinical professor of medicine at UCSF and provides care as an attending physician in the Division of Palliative Medicine. Between 2009 and 2021, she served as the director of the Supportive and Palliative Care Service at the Zuckerberg San Francisco General Hospital, and in 2003, she became the medical director of palliative care here at the San Francisco campus for Jewish Living. So please join me in a warm welcome to Dr. Sudore, and I know you're going to enjoy tonight's presentation.
Thank you so much for having me. It's wonderful to be here. I haven't been here since they did the renovation in 2020, and it looks beautiful. So thank you so much. I'm hopefully going to be giving you some practical advice today about ways that you could maybe do some of your own planning for medical care, or you could help somebody that you care about do their own planning, and hopefully we'll be able to answer your questions as well. So the title of the talk, as you can see, is My Choice, My Voice, Making Informed Medical Decisions at Every Age, and I'll tell you a little bit about our program, Prepare for Your Care. Folks thought it might be helpful if you heard just a little bit about my background and how I got interested in what I'm doing. I will tell you, way back in medical school, I started working with a student-run homeless clinic, and I realized really early on that we in the medical field don't provide easy-to-read information to patients for people to be able to make their own medical decisions. So I got interested in what's called health literacy, or ways that we can translate medical language or legal language into words that people can actually understand to make informed decisions. So that's how I got interested in health literacy and informed consent. And I also realized in my work as a geriatrician and as a palliative medicine physician, patients and their families are often not empowered to speak up for themselves, to be able to know and decipher all the medical information that's going on, and to get the medical care that they wanted. And so I sort of tried to pull all those things together to create some health education materials for patients and their families. I'll just tell you really quickly that we have a really wonderful team that comes together to create the materials that we have, including a team at UCSF, but we also work with a legal team at UC Law to help us make sure that our easy-to-read advanced directives in our programs actually are legally valid in all 50 states. And we work with also a very large community advisory board. So it's really important to us that all of the materials that we create are what we call co-created with patients, with caregivers, with people in the community. And I'll just tell you that we are always getting feedback. Love to get feedback tonight. We can't always act on it, but when we get funding, we are always constantly updating and trying to make our programs better. So tonight I'm going to be talking about advanced care planning, or ACP, and what that is. I'm going to be telling you about a program that we have called Prepare for Your Care, and a program called Prepare for Their Care. And all of our materials that I'll be talking about tonight are free to use by anybody. So one of the things that we often hear when we ask people, what is advanced care planning? Most people will say, well, that's about death and dying, and that's about the end of life. And I have to say, the old definition really has been to have people make treatment decisions in advance of serious illness. And when I say treatment decisions, it's usually, you may have heard about CPR or breathing machine, and we use things called advanced directives or PULSE forms. You may have heard of those, physician's orders for life-sustaining treatment. And I think clinicians like myself and lawyers, we often like things to be put into nice little teeny tiny boxes and check boxes. Did you do this? Do you want this? Yes or no? But we know that people are complicated. Families are complicated. Medical situations are complicated. And sometimes those check boxes don't always work. And I think when we're thinking about the problems, the forms are good. But if we're only focusing on the forms and we only are focusing on check boxes, there's things that research have told us that basically maybe this isn't the best way to go. So one thing that we know are that these forms are not always available when needed. You may know or know people, I can tell you I do in my own family, that have these, from 10 years ago shoved in a back drawer somewhere. They also have done research where, again, if you just have the form, but you don't have a discussion, the person who might be making the decision, often called a surrogate decision maker, or the clinician, their knowledge of that person's wishes in multiple different situations is no better than chance. And we also know from research that the form alone, without discussion and better preparation, leads still to surrogate decision makers having stress and conflict. So the question is, are advanced directives in and of themselves enough? And I'm going to read you a quote from one of our many focus groups from a caregiver. She said, "We got the DNR, or the do not resuscitate, in writing, but in making the decisions, which there were many, that was just one. Because the first decision was to put him in a nursing home. We were married 30 years and I could no longer take care of him. The second decision was whether to put him on a feeding tube because he had stopped eating and I wasn't ready to let him go." So some people will say, well, why not just designate a surrogate decision maker? My family will just take care of it and we can just be done with this. The problem is, again, from research, we know that oftentimes surrogates don't know that they were chosen. And I can tell you as a palliative medicine physician, going into the ICU and you pick up an advance directive form and somebody's name was written on it to make medical decisions for someone. And I can't tell you how many times people look at me like a deer in the headlights. They had no idea that they were chosen. They had no idea that they would have to make these decisions. And again, without preparation, surrogates' knowledge of what the patient wants is no better than chance. Studies are showing that family members live on with stress, anxiety, and PTSD from these situations. And we know that surrogates often use their own hopes and desires when making medical decisions that may not be what that person may have wanted. So I'm going to tell you a story about my own grandparents. So my grandfather, in his last year of life, had fallen and broken his hip, and he went into the hospital, and they pinned his hip, and he was immobile for 3 days, and then they moved him to a nursing home. He had diabetes, and unfortunately, because they hadn't moved him and he had really bad circulation, he wound up having ulcers that went on both of his heels all the way to his bone, and he never recovered. And he spent the last 6 months of his life going back and forth from the hospital to the nursing home, into surgeries, multiple treatments. His kidneys were failing, and nobody had had a conversation with him about what was his quality of life, what did he want. And I sat down. I didn't want it to be me as his granddaughter, but nobody else was doing it. So I sat down with him and my grandmother, and he was very clear with me. He said, "I am tired. I'm not afraid of dying. I don't want any breathing tubes. I don't want any shocks. I don't want any pushing on my chest. When it's my time, please just let me go." And I turned to my grandmother and I said, "This is really hard." She had tears in her eyes. And I said, "I just want to make sure, if you heard what Grandpa said, and if the doctors ask you what to do, what would you tell them?" And she said, "Well, of course I would tell the doctors to do everything possible to keep my husband alive." And this was after a 45-minute conversation, and I thought, oh my goodness. So I'll come back to their story in just a moment. But I think one of the things that we realized, again, in the research that we've done and talking to people in the community, is that we really need to redefine what we mean by advanced care planning. So it's not only about life-sustaining treatments, it's not only about CPR and mechanical ventilation, but we need to do a better job of preparing people and their family members for communication so they can speak up for themselves and for medical decision-making. And if you think about it, we have sort of Lamaze classes and other things for people when they're about ready to give birth, but we don't do any preparation for people when they might be facing serious medical decisions or planning for the end of their life. So the new definition of advanced care planning, which has been defined by international experts, is that it is not a one-time event, but it's a process that supports adults at any age or stage in health in understanding and sharing their personal values, life goals, and preferences regarding current, right now, as well as future medical care. And it prepares them and their surrogate decision makers for communication and medical decision making. So if we think about care planning over the life course and preparation, the benefits that we found if you do this kind of preparation, again, is that it prepares patients and caregivers for decision making. It improves satisfaction with communication with the medical team and satisfaction with medical care. It actually ensures that patients get the medical care that they want, and instead of increasing, it decreases caregiver burden, PTSD, and complicated grief. These are really important things. Unfortunately, we know that a lot of people don't engage in advanced care planning. So the advanced care planning rates are about 33%, and they haven't really gone up in the last 10 years. We also know that these are lower in people who have racial or ethnic minority populations. It's only in about 15 to 20%. And we've also find that only 10 to 20% of people actually discuss their wishes with their medical providers. Studies that were done actually in San Francisco have shown that in the ICUs here, about 20% of people have absolutely no advanced care planning information on their medical record at the time of death, leaving family and clinicians really unsure about what to do for them. So now I'm going to talk a little bit about how we've thought about co-developing some of our materials to kind of address some of these things with patients, caregivers, and communities, and some of the things that we thought about and wanted to make sure that were included. So this is about health literacy. This cartoon says, "You don't call this a legal document, do you? I can understand every word of it." And I have to say, it's been amazing to me. When I started this work, I got so much pushback from lawyers, from risk management people, that if you make things easy to understand, it's not in that legal language, that's going to be a problem. And we actually find the exact opposite. People can actually make better informed decisions if they can read things. So you may be surprised to learn that the average reading level in the US is only at the 8th grade level. And for Medicaid and the elderly, it's actually only at the 5th grade level. But all of our forms, advanced directive documents, informed consent forms, are all historically written beyond a 12th grade reading level. And this is just a picture of one of the advanced directives that have been in use, or still in use here in California. And you can see it as teeny tiny font, and it's very hard to read. We also had to address things like digital literacy. I think what's really wonderful is that even older adults are starting to use more and more technology. So 73% of older adults use the internet, yet only 60% are able to send an email or fill out an online form. So if we're going to create something that's online, we have to make sure that it's easy to use and easy to find and easy to navigate. We also really wanted to think about cognitive issues because some people have some, cognitive impairment. So we use something called cognitive aware development, where we use memory aids, limited decisions per page, and trying to make that easier. The other thing we know is that many people in the US speak a language other than English, so 60 million of them, and 40 million Spanish speakers and 3.4 million Chinese speakers, including a lot of them in our city here, and so we really needed to think about different languages. And there's also really important things to consider in terms of culture and racism. So many people hold what we call non-Western views on autonomy and decision-making. In our research, we find that 20% of people who can make their own decisions say that they don't want to. They want their family or they want somebody else to do that. And 20% of people will report that they don't have anyone that they trust to make medical decisions for them. And that could be for many reasons. So we have to be able to support people who are in those situations. And unfortunately, many people in our society have experienced racism from our health system. And our health system has not always shown itself to be trustworthy. And because of that, again, we have to address those things when we create our materials. I think it's also very important that we also address what matters most to people. So again, in our research, we find that what matters most is not the treatment, like CPR or mechanical ventilation, but what is the outcome of treatment and how will their life be? And I have this picture here of a cart before the horse. I think we're trained in medicine to ask people, do you want CPR or mechanical ventilation? Which is what we call the cart, when we really should be asking again, how do you want your life to be? What does quality of life mean to you? That's really the question, because you only want the treatments that are going to get you the quality of life that's important to you. This is a quote from one of our focus groups. Are we reviving him, sticking the tube in so that he can suffer more? I guess it goes back to what happens if you revive him. Is he going through that whole process again it's the end result. And so really trying to help clinicians and patients really think about what is the end result that's important to them. So one of the other things that we needed to address was what we call surrogate leeway. So surrogate decision makers may need to make decisions that conflict with a patient's prior preferences. I see this all the time as a geriatrician and a palliative medicine physician. So somebody whose wish is to, die at home, but the only person that could care for them is a frail 90-pound spouse who can't actually take care of them or make sure that they're comfortable. Or somebody who asks to withdraw care, they may benefit from transient treatment, and people may need to make a different decision sort of in the moment. So studies have shown that surrogate burden can be eased by giving them permission to consider factors other than prior wishes during in-the-moment decision-making. And this is what we call flexibility or leeway. You have to trust your surrogate decision maker definitely for this, but it is still an extension of that person's autonomy if those discussions are had ahead of time. And this brings me back actually to my grandparents. So as you recall earlier in this talk, my grandfather said that he wanted a natural death, he was ready to go, he wanted to go peacefully, and my grandmother said, please do everything you can to keep my husband alive. So when I turned to my grandfather and I asked him, well, how do you feel about that in terms of flexibility or leeway? He said, I'm ready to go, but if it helps your grandma, I tear up every time I read this. I'm ready to go, but if it helps your grandmother to feel, that she did everything possible for me, even if it's because she doesn't want me to go, that is okay. She's the one that has to go on living with her decision. If this is what she wants, then this is what I want because I love her. And this totally changed the way that I think about advanced care planning. And my grandfather, wound up having a heart attack in his nursing home. His heart stopped. They did CPR. It wasn't successful, and he died. My grandmother felt like she gave him, the best chance, and it actually helped in our subsequent conversations with her, and I'm a little teary-eyed because she died last year at the age of 102. She was a very sweet woman, so anyway, this really changed the way that I think about advanced care planning and the things that we can do to sort of prepare our surrogate decision makers for decision making. And so when we think about what are the missing puzzle pieces that all need to kind of come into patient education, materials to help, is that we realize that some of these missing pieces are that we really need to prepare people with skills to identify what is most important to them and how they want to live, what does quality of life mean to them. And then really the skills, how do you actually talk to your family and friends about that if they're available? How do you bring this up with medical providers? And then even if you know what's important to you, how do you then take that and make an informed decision and prepare your caregivers? So this gets again to our Prepare for Your Care, which is really based on this new model of advanced care planning. So not only thinking about life-sustaining treatments, but really preparing people, again, for communication and medical decision-making. And again, we're pulling in all of those things about health literacy and digital literacy, language, culture, cognition, what matters most, leeway, and preparing surrogates. So if you go to the website, it's prepareforyourcare.org. It's an online, secure advanced care planning program with videos and easy-to-read advanced directive forms. And there's two parts of the program. One is for people who want to do their own medical planning, and the other piece are for caregivers who want to help somebody else do their medical planning, or if they're making medical decisions for someone else. I think part of the crux of the program is really finding out who and what do they value and why. So Prepare uses video stories and, again, the easy-to-read advanced directives to help people make medical decisions based on their values. The program walks people through 5 steps. So 1, choose a medical decision maker. That's that surrogate decision maker. Decide what matters most in life. Choose flexibility or leeway for your decision maker. Tell others about your wishes, and ask doctors or other medical providers the right questions. One of the things that was important to us, and we heard from patients and caregivers, is they didn't want to just be told that they should do something. They wanted to be shown how to do something. So the cornerstone really are these how-to videos. So how to ask somebody to be your medical decision maker, or how to ask doctors the right questions. And everything's written at a 5th grade reading level. There's narration of the text if that's what people want, and closed captioning. And the program integrates our easy-to-read advanced directive legal forms for all U.S. states in English and Spanish, and a growing number in Chinese. And again, we worked with our partners at UC Law to make sure that these are all valid. The advanced directives may look different than some of the forms that you might be used to, because we really wanted to save space so that people could write their values and why they made their decisions, which I can tell you at the bedside, it's the why that is really important, but it really focuses on quality of life. If people go through the step-by-step program, they're answering questions about themselves, and what's nice about the program, if they actually do it on the website, is it pre-populates the easy-to-read advanced directives so that those are ready to go and ready to be printed. People can also go directly right to the advanced directive and just fill that out. And as people are filling it out, there are these little question marks that people can click on if they have questions that might have videos that will pop up and help answer questions for them. We have done decades of research, but I'm not going to bore you with all of that tonight, except just to tell you that we found that the PREPARE program helps to make advanced care planning easier for patients and clinicians, and we've done this in randomized control trials. And I've sort of taken all of our research over the last couple decades and just put it onto one slide to make this easier. But we've done some randomized control trials in a total of over 1,400 English and Spanish-speaking older adults. In the trials, in the study, what we did is we gave these materials to patients, call this patient-facing, but we did nothing on the clinician side and we did nothing on the health system side, because we wanted to know how much bang for our buck could we get if we just gave these easy-to-read materials to patients. And we found that it primes patients to do their own advanced care planning, and it decreases what we call disparities in advanced care planning. So at the end of our trials, we found that 98% of people who reviewed the PREPARE program were able to engage in some form of advanced care planning. And when we looked in the electronic health record, that the rate of advanced care planning documentation went from 8.5% to 43%. I think the thing that we were most happy about is we actually audio recorded 400 primary care visits after people had viewed PREPARE, and we found a 50% greater sort of patient empowerment, where patients would come in and they were empowered to speak up about what was important to them and bring in their own advanced care planning information. And then, not surprisingly, clinicians were 50% more responsive to that. In addition, we found that we had 50% greater ratings of patients saying that they were getting the medical care that was important to them. So that went up from 33% to 60%. We also found, again, that this decreases disparities, meaning that this works equally well across many different patients from different cultural backgrounds. And we think that this is because we've co-created these materials with the community. We're trying to deal with these, outdated models of advanced care planning. So it's not just about check marks, but it's about quality of life. And these other things that we've talked about, including literacy and language. We've had really good success doing this at UCSF. So we started putting some messages that were sort of automated into the electronic health record to give people access to these materials. And in 2019, when we started, there was about an 18% documentation of advanced care planning in the medical record, and that in 2023, that's gone up to almost 70% for all patients. And when we look at patients who have serious illness, that's gone up to 91%. So I'll just say that there are a lot of different PREPARE educational materials for different audiences, including clinicians and caregivers. We have pamphlets, we have the advanced directives. There are other things on there, including a quick start guide. If people are new to using the internet, they could do this through, step-by-step process about how to get on the website. For people, we found that people are using our videos and actually conducting what we call group visits. So they can do group medical visits, but also group community events. And so we created a toolkit for these group movie events that can be put on really by anybody. It doesn't have to be a clinician. Tried to make that really easy. And for any of the clinicians in the audience, or caregivers for that matter, we have these simple scripts where we tried to give people the language that they could use. They don't have to guess if they want to start an advanced care planning conversation. And I'll end just by telling you about a new caregiver program that we have. So that's the Prepare for Their Care. And there are two parts to the program. So one is how to help other people with their medical planning. So if you want to help somebody else complete an advanced directive or start these conversations. And then how to help make medical decisions for other people. Because we were hearing people were coming up to us and saying, well, now I'm in a situation where I have to make these decisions and I don't know how to do that. So the first part of the program, how to help other people with their medical planning. There's information here, important ways that planning is different for each person, how to bring up the topic of medical planning, how to ask other people about their medical wishes, and how to help other people write down their medical wishes in an advanced directive. There's some bonus videos, so what to say if you learn that you are not the decision maker, which oftentimes can happen, and what to say if you're asked, but you don't want to be the decision maker. So information there as well. And then for people who are in a position where they need to make medical decisions for someone, we've got information about how to ask the medical team questions. How do you actually make decisions for other people? Oftentimes people in a situation where they have to update other family and friends, so how to talk about the decisions that you made for others, and advice from other medical decision makers. And some of our bonus videos are how to help even if you are not the decision maker, how to ask somebody else to be the decision maker, and what to do when families do not agree. There's other information here on the website. Again, this is all free if you want to learn more about what is medical planning, what are advanced directive forms, if you want to know about some of the terms and facts about advanced care planning or other resources, including what is palliative care and how can that help. And with that, I will end.
So, Rebecca, so wonderful to hear the scope of your work. And this has really been decades of work condensed down in 20 minutes. Amazing. I would love to hear just a little bit more about particularly Prepare for Their Care, since there are probably a lot of people with us tonight who are in that position. And so I guess, from the Prepare for Your Care that you've been working on for years, what are the things that you feel like you learned in that process that really kind of informed and kind of the added parts to support the people who are making decisions?
Yeah, so what we learned from Prepare for Your Care to create the Prepare for Their Care program. Yeah, I think, we have, again, heard for years, caregivers would come up to us and say, we love your program. I did my own advanced care planning, but my husband or my sister or my friend won't talk to me, and I don't know how to bring it up. Can you help me? What do I say? Or, oh my goodness, my loved one can no longer make their decisions, and now I need to make them. And I maybe even have this advanced directive, but I just have no idea how do I go through this process. So I think we learned sort of over time that we needed not only to support patients, but their families as well in this process.
And what are kind of the early responses for people to those materials? What are the things that they're appreciating about them? Yeah,
I think the videos really give people simple language so that they could start these conversations and kind of walk them through how do you use the advanced directives, or how do you use the Prepare for Your Care program, and sort of decreasing the anxiety to sort of get started, and just really the practical examples, I think, is what is really helping.
So I want to ask kind of to maybe give some of the pearls of that, or a teaser. So I imagine that there are some people with us tonight who are in exactly that situation where they have a loved one who may be experiencing a serious illness or is at risk, and they feel like they need to have the conversation, either because they feel like, I don't know what I'll say in that situation, or worried about being in a crisis. But the person is hesitant about engaging in that conversation. What are the things that have helped start that conversation in those situations?
Yeah. I think what's really interesting is one of the best things to help start that conversation is when somebody's done their own advanced care planning. So if somebody does their own advanced care planning, and I have to tell you, I've done this with many of my family members. If I've done my own advanced care planning and then I say, oh, hey, I've completed this advanced directive and I want to tell you about it, and this is what my wishes are, it oftentimes completely opens the door to start having that conversation. That other person might say, oh, I guess I should be doing that too, and I've been thinking about this. So that's one thing. Though I will say that oftentimes caregivers are so distressed. Sometimes it's too much to think about doing your own advanced care planning in that moment to start that conversation. So if you haven't, there are many other things that you can do to start the conversation. And what we've heard from caregivers, that the things that have worked are basically just to tell that person that they really care about them, that they are there for them, that if they ever needed someone to go to the doctors with them or help them make any decisions, that they're there for them. And that usually can open up the conversation, because then the person, can say either, I don't want you to do that for me, and then or thank you and I do, and then the person can say, like, it would really help me to know what is important to you. And there's this program. Like, you don't even have to know what to say. You can just point them to Prepare for Your Care, because it'll just walk people through it step by step. And that's also what we've heard from caregivers. It really makes it easy, because they don't have to know what to say. They just have to click the button on the website, and it walks people through the whole thing.
And the other thing that is great, I think, about the Prepare website is that you can actually go in and create an account. So it's not like you have to sit down and do the whole thing at one go. You could tackle one of the steps or a part of one of the steps and do it kind of as you're ready for it and what you know.
Yeah.
And I think that's the other thing too is, how do you, like it might not happen the first time, right, that you start that conversation. So you may need to take kind of a different opportunity, something that comes up that might prompt that person.
Yeah. I mean, I think we call it like planting seeds. So I think, the one thing that I've learned with my own family members, this may resonate with people, is that you can't really force people to do something they're not ready to do. So all you can do is offer the opportunity. And sometimes people are not ready, and that's okay. But you might be surprised. It might be next week. It might be next month. It might be 6 months from now. It might be years from now. That has happened with me, with my own family members. But when the time is right, they know that you are supportive and you're ready to help them.
Yeah, you're opening the door, like planting seeds that this is something that you're open to talking about.
Yeah.
I'm curious, all of the slides at the end was like an amazing amount of information about all the different ways that you've thought about using Prepare. What are some of the interesting ways that you've seen people use the material that maybe you didn't imagine at first?
Yeah. Well, I think, like I was saying, we created so people can go through the website step by step. And we also created sort of movies of the whole step. sort of thinking that there might be some people that don't want to click through and they just want to watch the movie. Well, we were surprised to learn that people were using those movies, like I was saying, to do movie events in the community, which was super cool, in libraries, churches, senior centers, and things like that. So that has been really fun, and that some collaborators of ours started using it to do, group medical visits as well. So that has been really great. And then, like I said, I think we've learned a little bit about needing to help the caregivers, because we started learning again that caregivers were maybe doing their own advanced care planning, but they found it as a great tool to kind of help other people do it as well. I think we were talking earlier about financial planners. I just learned that my financial planner is using our easy-to-read advanced directives, which is great. But that's another opportunity, I think, lawyers and financial planners to help kind of get this information out.
Yeah, that's great. And, I think that the story that you told about your grandparents is just so compelling. And I, had a similar experience as a palliative care physician. I do this work, all the time. And yet that article that you wrote telling this story about your grandparents really fundamentally changed kind of how I think about some of those conversations when there is that tension. So you gave us some of the kind of ways that's changed your thinking. Could you say more about that and kind of how you think about people who, those other values about the impact on their family or other things play into it?
Yeah. And it's interesting because I've given this talk many times, and I wrote that paper about my grandparents many years ago now, and it hits me every time. I think that it won't, and every time that it does. I think because there was so much love between my grandparents, and I think people make decisions for a lot of reasons. So they might make decisions for themselves because they don't want to be uncomfortable, or they know what their own values are. But I think that sometimes people make decisions out of love. And I think initially, I will tell you, as a granddaughter, but also as a geriatrician and palliative medicine physician, I was very upset initially about this decision. But it's what my grandfather's love for his wife was stronger than his own desires for his own, decisions about his medical care. And those need to be honored and respected. So I think sometimes it's not straightforward. And again, people make decisions for many, many different reasons.
And so, if your grandfather were doing prepare, one thing might come out. Where do you think, how do we account for those things that are like, but if my family needs to do this for me, is that maybe under leeway? Where do you see that?
Yeah. So, yes, step 3, under leeway. And there's space on the advanced directive that actually asks about leeway. So I'll tell you that some people don't want their medical decision makers to have any leeway at all. They want to write their medical decisions on the advanced directive. They do not want it changed. They don't want it changed under any circumstance. And that's okay. But the forms allow you to mark that down. But my grandfather would have been marked the total leeway, whatever you want to do.
Mm-hmm. Yeah, that's great.
And I would say the other reason to do that, again, being a clinician and, also sitting on ethics committees, this is where sometimes things get a little dicey, because if people haven't sort of talked about leeway ahead of time or documented an advanced directive, if somebody has documented something on their advanced directive and a medical decision maker or family member comes in and says, well, actually, like my grandmother, I'd like to make this different decision, it put everybody people don't know what to do. Mm-hmm. But if my grandfather had the advanced directive that said total leeway for my wife, we would have been like, okay, that's what she wants, and he said it was okay. So, yeah.
So you can kind of have peace with that in some ways, of knowing that that was actually the most important part,
right,
for him. Yeah,
right.
Yeah. And how, I think, one of the things that you mentioned in the prepare for their care is this, question about when we're asked to be decision makers. So I wanted to ask a couple of different scenarios, how what advice you would give for someone who's approached to be the decision maker, for a family member or a friend, colleague, does not feel equipped or comfortable to do that. How would you guide them to respond?
So you're asking if somebody asked you to be their medical decision maker and you didn't feel like you could do it.
Yeah.
That's a really important point because I think a lot of people feel that way. So I think there's a couple of things. One is you could ask, or you could say that you don't feel comfortable, and maybe it's a conversation that it's something that you don't want to do alone. Maybe you want other family members to be involved so you don't have to feel like you're making that, decision alone. So that's a conversation that you can have. The other thing is that if under no circumstances do you feel comfortable doing it, it's important to say that because it's better to find out now so that person can find somebody else before there's a situation where they can no longer speak for themselves. Yeah.
Yeah. And the opposite scenario can definitely come up where you're in a situation where you find out, hopefully before the ICU and other kind of crisis points, you find out that the person who you care a lot about has picked someone else as their decision maker.
Yeah.
How would you have that conversation with the person who you wanted to make a decision for?
Yeah, we see this a lot where, maybe there's a family member and they're the ones doing the day-to-day care. They're the ones taking them to the doctor's appointments. They're the ones coming into the house and helping. And then something happens and that person can't make decisions for themselves and somebody else's name is written on an advance directive. It's the, firstborn child who lives across the country who doesn't know anything that's sort of going on. These were very real scenarios that came up when we were talking to caregivers in the community. And that's why we have one of these videos in Prepare for Their Care, because this does happen. So I think there's a couple of things. First of all, if you find out that you're not the medical decision maker while that person still has the ability to talk with you, I think it's more than reasonable, and there's an example like this on the website, of saying, hey, I notice that, that I'm not the medical decision maker, and I feel like I know a lot about you and your care, and I'm just wondering, is that still what you want to do? Because I feel like I could do a good job, or I'd want to do a good job if that's really what the person, wants to, again, start that conversation. And I've seen situations where that has happened and people have come in and changed their advance directive, or they've set up a situation where people could make decisions together with this other person. Oftentimes, I'm sure you see this as well as a palliative care physician, you don't get a chance to have that conversation ahead of time. And this long lost relative from somewhere else flies in, and the person who's been doing the day-to-day care just sort of doesn't know what to do. And I think, again, there's an example that caregivers helped us create in the website, basically just, talking to that person and saying, hey, I know this person really well. I know all of their medicines. I've been going to their doctor's appointments, and I'm here to help you. And 9 times out of 10, that person really wants your help.
Yeah.
So there are ways to help even if you're not the person written on the form.
Yeah, that's great, because I think a lot of times that person who's on a form but didn't know, or they've been out of touch, that's a big burden to carry, especially if you don't know, you haven't had contact with that person recently, you don't know. So, gentle ways to offer help in those situations is great. And, we do have some folks in the audience tonight, I think, who may be healthcare professionals themselves. And, I wonder how you would counsel people who are healthcare providers who, for some people, in this world, but especially in our city, we have a number of people who don't have, a trusted friend or family, and actually they feel like the person they trust is a healthcare professional, and they'd really like them to be their decision maker. But that's a hard position to be in a kind of a professional relationship that may be close, but it's different. So how would you counsel people who are approached as healthcare professionals to, when they're asked to be can you be my decision maker?
Yeah. So in California, they cannot be. It's actually against the law because of potential conflicts of interest. But it's hard, right? Because you care about this person and they may not have somebody else. I think as a medical provider, I think that's why it's super important to document. It doesn't mean that you can't have a conversation with someone about what their goals and wishes are, and then to document that and make sure that that gets into the medical record. If you're someone who doesn't document in the medical record, you could still help that person complete an advance directive and then get that into the medical record. So there are other ways to get that important trusted conversation into the places where it could still help that person.
Mm-hmm. Yeah. And how would you guide someone who really doesn't have someone who they feel like they can trust as a surrogate decision maker? I'm sure prepare for your care would be your top recommendation. But after that, what are the things how can you try to make sure that all of the work that you've done and prepare gets to the right places and in the right moment when needed?
Yeah. Well, I just want to sort of normalize it too. Again, from our research, 20% of people will report that they don't have someone that they trust to do this. So it's actually very common. And I think, again, for those people, as you said, we really sort of recommend that they go through Prepare for Their Care, that they complete an advance directive. And I think more so for that person, it's important for them to make sure that the advance directive is in their electronic health record and, having these conversations with their medical providers, again, so that the information is there if and when they need to go, to the hospital. I will say too, I feel like it's our job as clinicians to make sure that we make many copies of these forms for people, because people may not know that if you go to UCSF and then you go to Sudore, maybe you go to the VA, they don't share medical records, unfortunately. So I think particularly for people who might go to multiple different places, to make sure that they have a copy for themselves, even if it's not a medical decision maker, maybe a copy with their friends. If they live here, maybe a copy somewhere here, a copy at, at the places they get medical care. And medical providers, we should be making copies for people so that they can do this.
Great.
Yeah.
Where do you see, what's next? You've done tremendous amounts of work going from the form that you showed us on that slide that was all legal language and hard to read and all of that, and the prepare for your care and now prepare for their care. Where do you feel like the gaps are, and that, there's work that still needs to be done in advanced care planning?
Yeah. Well, there's so many things on our roadmap that we want to do and always just waiting for funding to do. So I think that there's a lot of things that we'd like to translate into more languages. We'd actually like to create a book of our materials, because some people just want to go through the book and not necessarily watch videos or do the online things like that. And I think that there's more things that we can do to engage caregivers sort of in the process. The other thing I will say about advanced care planning as well is that we've been really trying to kind of start things earlier, right? So kids go off to college and they have to designate an emergency contact. Well, that's your medical decision maker, that's care planning. So I think that there are things that we can do and kind of bake it into just what we do regularly in medical care, and it doesn't have to be this big, scary thing. So I think starting earlier and then also sort of baking into the process so that we're reassessing over time, because it's not a one and done thing. People's lives change, their relationships change, their health changes. And so trying to figure out how we can make this easy to update and change. To your point about if people go on to the website and they, create a username and password, what's nice is, first of all, if you're in California and then you go visit, in Florida, you can just hit a button and it will convert your advanced directive from California to Florida. And it will also save your answers. So a year from now, if you change your mind about something, you could just go in and change it and you have your new advanced directive.